So Renee wanted me to go over what the education system is now for pharmacists. So it is a doctorate of pharmacy degree, and a lot of people get their bachelor's before they do get accepted into pharmacy school. And to work clinically, a lot of pharmacists do residencies. So you have a 1-year residency, which is more generalized to be a clinician, and then you have a 2nd-year residency if you want to specialize in like infectious disease or oncology.
Or like 50 other things, just for
Or,
example.
yeah, it's just a few examples. All right, and my name's Jaco Fornengo, and I'm in my last year of pharmacy school. Thank goodness, almost there. And I'll be going over Pharmacist-Physician collaboration practice agreements on diabetes. So let's start off by saying, what is a CPA? So it's a formal agreement in which a licensed provider makes a diagnosis, then supervises patient care, and then refers the patient to a pharmacist under a protocol that allows the pharmacist to perform specific patient care functions. Okay, so let's break this down. So the physician outlines what the pharmacist is allowed to do, and that's off of his clinical judgment and what he feels comfortable with. The physician can modify this contractual agreement at any time, because there's always unforeseen things that pop up, and this is best for whatever the patient needs. And so federally, there's like a loose guideline of what CPAs are, and it's normally regulated more by the states, and so it can vary widely from state to state. And also, specifically, the patient care functions can be very wide range of things, and it's whatever the physician feels comfortable assigning to the pharmacist. So a few of these examples in CPAs are like performing patient assessments, like your physical assessments, ordering drug therapy-related laboratory tests. Obviously, they have to be related to the disease within the CPA, and they need to be indicated. Administer drugs if needed, but most importantly, selecting, initiating, monitoring, and adjusting drug regimens. So normally, like a physician will diagnose, and they can either initiate a therapy or automatically refer to a pharmacist. The pharmacist will then can initiate a therapy, monitor the therapy, and then adjust based off the monitoring parameters. And so specifically Wyoming's state laws on CPAs, Wyoming's awesome. It's very progressive and compared to a lot of states, but we still have a lot of work to do. So the written CPA must have the name of the practitioner and pharmacist on it, the specific types of medication therapy management decisions allowed, and that's allowed by the physician, a method for the practitioner to monitor compliance to make sure the pharmacist is going by the CPA and not dictating by himself, and also a provision allowing the practitioner to override the CPA whenever necessary, because ultimately he has the final decision. Also, medication therapy management cannot occur until a practitioner, the pharmacist, and the specific patient has signed a written order to allow this to happen to practice. And then the CPA must be reviewed and renewed annually by the pharmacist, practitioner, and the Wyoming Board of Pharmacy. That's also when any changes are made. And regardless if there's a change made, it has to be done annually and updated. And it's normally pretty quick, especially the Wyoming Board of Pharmacy. So support for CPAs. In 2003, the CDC said, patient care services provided by pharmacists can reduce fragmentation of care, lower health costs, and improve health outcomes. As well as the U.S. Surgeon General in 2011 gave a report saying, within federal healthcare, utilizing pharmacists on the primary care team to prevent and manage disease and provide patient care services has been one of the most evidence-based, proven, and time-tested strategies to mitigate similar demands. Also within that report, it said that pharmacists' formal education appropriately prepares them to successfully perform clinical services related to the prevention and control of disease through medications. Pharmacists are also well positioned through accessibility, expertise, and experience to play a much larger primary care role in the United States healthcare system to meet these demands and improve healthcare delivery and the health of the nation. So I think the biggest thing to take away from this is how well positioned pharmacists are, especially in rural communities like in Wyoming. Think about some patients that are hours away from a hospital, hours away from primary care physicians. the closest provider might be the pharmacist, and I think we're in a great place to give that patient the best healthcare possible. So now let's talk about what they are versus what they're not. So CPAs are a way to promote interprofessional care, a way to distribute work due to workforce shortages. Primary healthcare providers are stretched thin across the nation, especially with the amount of paperwork and all the regulations that go into it. And I think pharmacists can release this burden quite a bit. They're a way to lower healthcare costs and a way to increase the quality of healthcare. And these last 2 points I'll go over with 2 studies done. CPAs aren't trying to cause rifts between interprofessional colleagues or a way for pharmacists to step on the toes of other practitioners. It's not trying to invade their territory, it's trying to supplement and help them and increase healthcare for the nation. And also, it's not having pharmacists work outside of their scope of practice, like we talked about before. We go to school for a long time and get a doctorate of pharmacy, specifically on medications. So now let's talk about changes needed to implement these CPAs. So we need a practice model to implement these effectively. So a lot of providers don't know about these and don't know that they're available. So we need to inform our healthcare community that this is a thing that's available and a way to lower the burden on our healthcare system. And so for this to be implemented as well, we need great communication interprofessionally. I think that's vital at all times, but especially with CPAs. Also, we need to educate our patient populace as well, that this is a thing and pharmacists are allowed to do this, and that we go to school to manage medications. And as well as the biggest thing, I think, is the business model. Our country's ran on money, and without being reimbursed, something like this is never going to take a foothold in our country. So we need to implement payment mechanisms so pharmacists can get reimbursed. And whoops. Yeah, so this is a great way to lower costs and whatnot, but pharmacists still need to get paid and reimbursed. And hospitals aren't going to give something out for free without reimbursement coming back. So I'll start with our first trial. It was a randomized control trial. It's called IMPACT. So it evaluated the clinical outcomes of pharmacists' collaborative practice care versus physician-centered care in diabetes. It was a 6-month randomized study, and it was at 4 outpatient healthcare institutions in Asia, and most specifically Singapore. And this is crazy to me, that 1 in 8% of the population in Singapore is afflicted with diabetes. That's significant. Yeah. And so they interviewed primary care physicians, and they voiced that time constraints due to increased patient load was a huge barrier to providing a more comprehensive care. So the inclusion criteria, it was high-risk patients, greater or equal to 21 years old. They had uncontrolled type 2 diabetes, so they weren't at their goal met by your primary care providers. They had polypharmacy and comorbidities included, as well as, so type 1 diabetes and those unable to communicate independently were excluded in this trial. So your control versus intervention arm, they were randomized, so 214 patients were randomized into the intervention arm, and 197 were randomized into the control arm, which was your usual care. Yeah, your control arm received usual care with referrals to nurses and dietitians as needed, while your intervention arm followed up with pharmacists every 4 to 6 weeks with 20 to 30-minute meetings along with the usual care and referrals to nurses and dietitians. So our outcomes measured are A1C, which is a 3-month goal to see how your glycemic control is, systolic blood pressure, LDL and triglycerides, and then secondarily, there is PAID, which is a 20-question measuring diabetes-related distress. So the lower your score, the better. And then your DTSQ, which is Diabetes Treatment Satisfaction Questionnaires. So the higher your number, the better, as well as costs. So here were the results. Your change in A1C in the control arm was 0. There was no change at all in the 6 months. But your intervention arm dropped it by 0.5 percentage point, and this was statistically significant. Then your changes in blood pressure, LDL, and triglycerides, while not statistically significant, were showing trends towards better outcomes. And then your paid score was significantly better within the intervention arm at almost 8. And then your DTSQ scores were also significant statistically with 2.2 greater scores. And so your A1Cs, actually, you had even a bigger gap when the A1C started out higher. So if you're like at 10, 11%, you had even better scores with your intervention arm. And then your 6-month cost per patient dropped by $90 in the intervention arm in that 6 months. So now we'll talk about why and break down the expenditure. So consultation visits is roughly the same. And that's including the pharmacist visits. That's because the control arm had like 3 visits for physicians, while the intervention arm only had 2. So it ended up evening out. Lab tests, roughly the same. The big place that was saved is in medications. It was $410 for the control versus $318 to the intervention arm. So our total cost dropped by $90, and that's all because of medications, because of the intervention. And so they think that's because, pharmacists know medications. That's what we go to school for. And so we know better about the costs and whatnot, and better therapies, and it showed huge dividends in this study. Okay, now this next study, that last study was more about your clinical outcomes. This is more about your financial outcomes. So the DIMM clinic study was a retrospective cohort comparing cost effectiveness, cost benefit, and risk reduction. The 2 arms in the study were the DIMM clinic, which utilized CPAs with pharmacists, as well as usual primary care provider patients, and this was all at the VA in the San Diego health system. And this is something that needs to be studied because in the United States, it's estimated that the direct and indirect cost of diabetes is $245 billion. That's unreal to me. And a decrease in A1C of 1% can lead to $685 to $950 for healthcare savings per patient per year. And that can add up huge if it's per patient. The patient population in the DIMM study were adult patients with type 2 diabetes. They were complex patients as well with 12 to 14 medications. They averaged 8 comorbidities. Approximately 1/2 had a mental health diagnosis as well, and the majority were male and Caucasian. The mean age of the group was 62 years old. And so, this is obviously a VA populace. So the difference between the arms, there's no significant difference in demographics, and there was one significant difference in clinical parameters. That's just the DIMM arm had a mean A1C of 10.5%, while your PCP arm had a 9.7%. Your DIMM arm patients followed up with pharmacists during 3 60-minute visits over a 6-month period. And the study was done from 2009 to 2013 in patients in the VA San Diego health system. So outcomes that were measured are A1C reduction, percent of patients reaching certain goals, and then financially, the cost per percentage point of A1C reduction, the cost per additional patient at target A1C, medical cost avoidance due to improved A1Cs, quality adjusted life years gained, and that has to do with obviously quality of life and years lived without disease progression, and ICER ratios between the DIMM and PCP arms. So here is your cost per additional A1C benefit. So the DIMM patients actually costed $33 more per patient, but they had a reduction of 1.6% more than the PCP group. So that's a $21 cost for a 1% reduction in A1C, which I think that's completely fine. Yeah, that's a deal. And then, so your patients under 9% A1C, there was a 20.1% difference between the arms. So that's a $164 difference for 1% of the population. Under 8, even better, 28.8% of patients in the DIMM were below 8 compared to the PCP. That's $115 per extra 1% of the population. And then below 7%, which is normally your goal that you want, there was a 21.9% difference between the arms, which is $151 per extra percentage of the population. And then here we have our cost avoidance medically. And this was all done through the Archimedes model, which is tested in clinical trials to estimate medical costs with certain comorbidities that you put in. So the DIMM patients compared to PCP, there was a 5,287 difference per patient for a 3-year medical cost avoidance. And so a return on investment, for every dollar spent extra, you get $9 return in medical cost avoidance. And then your cost per additional quality benefit, that's your quality adjusted life years, which has to do with quality of life. Your 2-year estimate, the cost was lower and your qualities were higher in the DIMM population, so it completely dominated. And it's the same for 5 and 10 years. It's lower costs and higher quality of life.
Hey, can I give a couple examples in my experience of what this looks like? Because I didn't want it to be like too far beyond what's reachable. So I think Jaco's going to go on to see some of these examples in his rotations going forward. The 2 I had were also in my rotations. So the first one was at a rural hospital in Boise, Idaho, where the inpatient pharmacy literally volunteered because they weren't getting paid for it, to monitor the local PCP's patients on Coumadin. So they were managing 100 patients a month to keep them within range. And so they would make, if the patient was just initiated and so they needed a follow-up phone call that week, for the first 4 weeks or 5 weeks or 8 weeks, they'd get a phone call. Did you get your INR today? Yes. What was it? Or actually it got sent to them. This is your INR. We need you to do X, Y, and Z to modify your Coumadin dosing. So the pharmacists had that leeway to base the dose adjustments off of what that INR was. And that was done by inpatient pharmacists. And then another one that I saw and participated in was at the University of Utah in their, I forget, what's that new area down in Salt Lake that's kind of like, I forget what it's called. It's not Draper, it's the other direction. Daybreak. Ta-da, thank you. In Daybreak, they have a clinic out there along with a retail pharmacy, and those clinic physicians would refer any diabetes patients they couldn't get under control to that retail pharmacy downstairs where the pharmacist would manage their care. And so we would meet initially with that diabetes patient, first of all do a med rec, make sure we knew exactly what meds they were on, and then we would ask them, almost all of these were insulin dependent patients, type 2 diabetes adults obviously, and we would set up a schedule for them of when we were going to call them that week, give them a schedule, and have them, according to whether they could purchase however many, finger sticks that they needed for the week. Some people were really restricted. If they were Medicare, maybe they could only do it once a day. But some people could do it up to 4 times a day. So we would call them once a week to get their schedule, look at all those different numbers, and determine whether or not maybe they needed a bump in their evening Lantus dose, whether they needed to split that, whether we needed to adjust, tried to steer people way far away from carb counting because people aren't good at it, they're bad at it, and tried to make it so that this worked really well for them. And our goal was always to get them off insulin and managed on orals, and even to actually get them to the point where they no longer needed medication. But if we could get that off insulin in 2 years, that was our goal. But again, there's no mechanism to get paid for that. And so the reality is when you have another healthcare provider coming in and pushing that patient and can touch them on a weekly basis or even a monthly basis, you have improvement. But trying to get somebody to actually pay for that is a whole different ball of wax. So these collaborative practice agreements, I have a question for you. So in Wyoming, there's not like a overarching one. So we had an overarching one in Utah, which was this PCP could refer any patient he wanted down to us. We were allowed to check blood glucose sugars. We were allowed to call them in for whatever we needed, and we could do X, Y, and Z. So Wyoming's is patient-specific?
Yeah, so it's collaboration between a specific physician and a specific pharmacist. Mm-hmm. And then once a patient is diagnosed, they all three have to sign an order form that the pharmacist is allowed to work on that patient specifically.
Okay, so that's not so bad.
Yeah.
I mean, I guess I was thinking, I don't know.
They probably could still do state ones.
They probably could. I was just thinking that might clog up the works. Okay.
And like Renee was saying, this is great for chronic disease states like the coag, diabetes, asthma. And what's nice is when it's within a clinical setting, they can bill under the physician and internally tag it to the pharmacist. But in a more retail setting, or it's all pharmacists, can't really reimburse that way, which is difficult.
It does. It makes it really hard. On the other hand, if you were to view it as, say a whole bunch of our returning patients are diabetics, right? Would it be smart for the hospital to say, you know what, we're going to have our inpatient pharmacist follow you under a collaborative practice agreement. We know we're not going to get reimbursed for this, but dang it, it saves us on those 30-day readmits.
That's right. Absolutely.
In mind, right?
Absolutely. We were just talking on the side, having pharmacists as part of the care transition team.
I include Renee in our
Yeah.
email.
But,
We need to include Alex, guys, come on.
well, we've got lots of work.
Well, that's all I do is I grab that email and forward it on to the
Her
people.
favorite thing is, I have something fun for you.
Yeah.
Come on, fast.
You let me know, Renee, I'll add as many people as you
All
want.
right, let's do it.
Can I add something too? So it's talking about the follow-up with the patients with their medications. I remember when people get readmitted, because I go talk to them every time they're here. And one of the biggest reasons I see is that they are non-compliant with their medications because they can't afford their medications, especially the diabetic patients and the respiratory patients. Even when, when we still had the other pharmacy that had the med donation and 340B and all that stuff, and we would tell them about that, they still didn't utilize it.
Right.
So that's the biggest obstacle, is that they know they're not going to take their medicine, they know they're going to get sick again, and they know they're going to end up back in the hospital. So how do we get that
Right.
cycle to break?
And I think that's another place where in the hospital we decide, you know what, again, it's cheaper for us to send them out the door with this medication than it is to see them again in less than 30 days.
Right.
And so that has definitely come up. And I don't know if we decide as a hospital that there's a dollar amount we're comfortable with me giving out, or we just say, you know what, case by case basis, when case management calls, we do this. We just do it, right? This also has something to do with, now that we're talking about care transitions, there's also some concerns about transitioning to people to SNFs and LTACs. So I sat next to the mission people, it was the whole herd of them, at disaster training last Thursday and Friday. And they mentioned, so I guess one of the, and I had never really realized this because I've never worked in a skilled nursing facility or an LTAC, because it turns out they're too poor to hire pharmacists and have a pharmacy. So they get their meds usually from someplace out of state that prepackages all their stuff, but you can only do that if you know who the patient is. So if we send a patient over at 5 p.m., they don't have the meds for that patient.
Oh.
So how can we send them with first doses out the door? We know we're not going to get paid for those. We know we can't charge the patient for that because that's unethical. You can't charge for a dose you didn't administer. But so what? Maybe it's worth it for us to do that, right? And say, you know what, we're getting this so late to you in the day that there's no way you're going to get your doses tonight, nor your first doses in the morning, because we all know FedEx shows up at 10. Maybe you don't know that, but I do. And that's who delivers those medications for them. So let's see how pharmacy can help you better.
And to that point, that study that I read on schizophrenia, so they did a study on oral psych meds versus injectables, and giving long-term injectables reduced readmission rates within like 30%. It's crazy. So giving a long-term injectable instead of just releasing them out on oral medications drastically reduced the amount of readmissions.
And I don't know if we're having that problem in our behavioral health patient population or not, but that might be a really interesting thing to look at.
Although the majority of ours aren't taking their meds because they can't afford them or don't have
Right.
access.
Yeah, most of them can't afford them, or choose not to take them, or tell me they don't need them anymore.
So if we gave them an injectable here, that could last.
And it's easier to get a 2-week or monthly injectable and talking to that than taking their med every single day.
Right. And so what we need to do to prepare for that is, first of all, as an inpatient pharmacy, we haven't purchased in the past these long-acting antipsychotic injectables, but we can, right?
And then we just have to get the providers to be willing to order them. That's where you guys come in, you can help
Right.
them
You can help.
understand.
Right, exactly.
They're uncomfortable ordering
Yeah.
things like
This is
Yeah.
true. It's
Well,
not
you
my,
have
We'll
to-
go talk to them.
That's why
it's
you
not my
can help
favorite
them.
drug population either.
Yeah.
They don't work like they're supposed to in my mind. I give you a blood pressure pill, I want your blood pressure to go down. I give you an antipsychotic, I'm not sure what happens.
Maybe it works.
Yes.
And especially with a lot of them transferring to the state hospital for
Yes.
med stabilization, I wonder if that would be something that they would pay close to.
That might be a good question, so we could call and find out.
But once they're discharged from the state hospital, if they could come get an injection from us, so
Right,
they promise they won't come
exactly.
back. for a
Right,
while.
exactly.
Hey, here's your injection, and we'll see you next month, 33 days from now.
Outpatient on the floor, that'd be Sam's new gig.
Yeah.
I
Shannon
just had a
giving lots
question
of
about
shots.
the labs. So when you write an order for labs, is that reimbursable? Or do you have it under a doctor?
See, I think within the collaborative practice agreement, it may be, I'm not entirely sure. That's something that we really need to look into as well to get reimbursed for.
So I really think pharmacy is awesome in finding this niche and kind of taking over, and I think it's ideal. I would totally want a pharmacist to manage my meds, because I've seen how doctors just,
Don't.
oh, this hurts, here you go, oh, now this hurts, here you go, and pretty soon you're polypharmacy. But, I think that in getting it paid for, it'll be through the facilities. You see the benefit and the return on investment.
And that's a big thing down in North Carolina. There was a huge study done, and it was through a company that saw the efficacy through insurance because they were paying for all their employees, and then they referred them to pharmacists to manage, and they saved a ton of money. And so they reimbursed through the company instead of insurance companies or like the government.
And I kind of want to build on that because I'm not sure if I've told you guys this story or not, but ARUP in Salt Lake has their own inpatient clinic on campus, on their own little campus because they're self-insured. And so when I was there, they had approximately 10,000 lives they insured for their 3,000 employees. And they noticed that diabetes was one of their most expensive arenas. And so they did hire a pharmacist specifically for that reason to manage those diabetes patients. And how they lured their staff to come in and see the pharmacist about the diabetes meds is they said, we're going to give you your diabetes medications for free.
Oh.
So they gave them their diabetes meds for free as long as they would come see this pharmacist to manage that care, which was fascinating. And now it's been so successful, they've hired a second pharmacist to help.
And keeping employees healthy.
Keeping
and
them
not
healthy
sick time
and happy. It was
Keeping
really
yourself in
fascinating.
insurance
program.
Trying to keep them there.
Well, and keeping their families healthy so that they're not taking as much time off to go deal with it.
Right, exactly. So,
I could just see so much potential with that. I'm dreaming of things. And
I know, right?
Do you have any time left in your rotation?
Tomorrow. He's
Oh,
here
you're done?
tomorrow.
And he's gone.
I have his phone number, so we can get a hold of him. We can give him assignments on the side.
It would just be cool to see as a student to go over to spend a couple of days in the clinic.
I think that'd
Physicians
be a
know that you were
really good
there
idea.
and see if they really would use a pharmacist for advice or send the patient to you before they leave,
I
saying,
think that'd be
let's do
fascinating.
I
Yeah.
actually start
Yeah.
next week in the Donaldson Clinic
Oh, cool.
for my next
Ooh,
He's going to see
feed us
Dr. Donaldson.
information, just kidding.
so.
Well, I think you should share with us, though, how that works in a clinic. So has he
Yeah,
had
yeah.
pharmacy students before, do you know?
Yeah.
He has? Oh, hey, look at this. Man, we're getting best of
And his wife is a pharmacist.
And his
that's
wife,
what
Yeah,
was saying his
Veronica
wife
is a
is a pharmacist,
pharmacist.
and she's
Uh-huh.
usually in his office.
Yeah.
But that's fantastic. That's actually really great.
You know, in Baker, they had a pharmacist and a PA who did all of the Coumadin and
That, we've talked about that.
Yeah.
insulin, and the doctors loved it. They were comfortable with it, and they can follow up quicker than the doctors.
And there is that mechanism, just like he was talking about in the clinic setting, that if you utilize a pharmacist, you get to I can't remember if it's an add-on code or you get a bump up the code visit to the next level.
It's something.
I can't remember, because we did it in the pulmonology clinic, so just having me there to recommend these certain vaccines for the COPD population allowed them to bump up their billing.
Yes.
Yeah. Anyway, lots of fun things, right? Yeah, she's going tomorrow too. But I think we should explore that, because if like, say for example, let's just pick on the family practice docs. Say they wanted a pharmacy student, that would help us write another rotation that we could
Yes.
try to get people here.
And then, while during the rotation, everything's about money, you have to know about money in school, pharmacy school, to find a return on investment.
Yes.
And then that's what will sell it.
Guess what's cool, we get paid to have these guys.
Yeah, and then, so in Colorado as well, it was super recent, I think it's through Medicare, that if you reach certain laboratory values, you get a stipend. And so they've hired a ton of pharmacists in clinical settings, and it's showed dividends to get people down to those values. So they pretty much pay for themselves.
Right. One more question. Can I
Yep.
copy that PowerPoint?
Of course.
I have it so I can send it to you.
That, because the board really wants, the board's really good about looking at different avenues too, and if they can see a way to help this hospital be unique in the community and find ways to save money and make people healthy, I think they'd be willing to look at different ways to help fund something like that, another pharmacist.
That'd be good.
Oh, really?
Data related to their other pharmacists.
That'd be cool.
Very good. We're almost.
Oh, we're out of here. Okay, thanks, guys.
Thank you.